Τώρα, ευχαριστώ πάρα πολύ. Είναι τιμή μου που είμαι εδώ με εσάς. I'll be speaking in English though, because it is much easier for me. I'd like to thank Kostas Parias, Dr. Patagos, Dr. Vardas, and all the members who've come here. I think this is a fantastic conference and really highlights the expertise that's here in Greece. Costa had asked me to speak a little bit about differential balloon sizing. I just want to give some of our experience in a recent paper we've published. It's a very niche area and really only applies to the Sapien 3, but I think it's important in everything we do. We know our equipment and we get the most effect from the equipment that we utilize. That's my conflict of interest. So can we do better in TAVR? And I may say TAVI because I'm Canadian and that's how we started saying it, so I apologize. And I think we have to do better or continue to strive to do better because as we expand to lower risk patients, there's more to lose. When a patient comes in who's 70, who's healthy, who's a very good surgical candidate, then it's in our best interest and of course the patient's best interest that we have the best possible results. So we want to improve on paravalvular leak, on our permanent pacemaker use, prevent catastrophic complications, and also discharge patients early, because we know when we do that, they avoid other complications. So this is a paper that we recently published looking at differential sizing or over-inflating balloons within stents to tackle the gray zone areas that are very difficult and always give us the most pause where we're concerned about undersizing or oversizing. One thing I really want to stress is the S3 valve, the Sapien valve, is not a cylinder. Okay, so we have to remember that when we utilize this valve because we can expand the valve, the inflow of the valve expands more, so we have to look at not only the annulus, but we have to look at the LVOT and that interaction because as we put this in, we can, by knowing these sizes, we can decrease paravalvular leak, but also decrease pacemaker use. And these are examples of sizes with balloon overfilling. And again, the LVOT changes in size from the actual annulus, so it's very important to understand that. And every patient is different. As you review more and more CT scans, you realize that it may look oversized for the actual annulus, it may be undersized for the LVOT, or vice versa. So this is a sizing matrix, and there's a lot of numbers here, so I don't want to bore you with the numbers. It's in the publication, though. But we follow this, and we started following this around the same time as we entered the 3M study that was led by John Webb and David Wood out of Vancouver. And we thought that it was a good time for us to improve how we place this valve in. And talking to the engineers at Edwards, and they agreed with what we're doing, although we could not tell other people in Canada because it was out of their sort of, with no evidence and no clearance to do so. But we talked with them, and we felt this was a good way to size valves and annuluses, and you can see there where we tried to minimize the overexpansion. When we started TAVR, 15, 20% overexpansion was not uncommon, and that's why we had a lot of issues early on with annulus ruptures. And so we try to minimize that by right sizing as opposed to just regular sizing. So it's rare that we do only nominal balloon inflations while utilizing this valve in TAVR. These are the baseline characteristics. So we did a prospective cohort of patients, 102 patients in total. And you can see that still in Canada, our STS score is on the higher side only because we don't have access to utilize these valves in everyone or as many people as we would like. I think very different than the Northern European experience and the American experience now. I don't know if anyone else comment on that, but that's my impression. And that is changing now in Canada. Many patients had previous bypass surgery, previous PCI, permanent pacemaker use. Also, atrial fibrillation is a very high number, and these are patients that still remain a mystery as how to best treat them afterwards. And again, you can see that most of the patients actually have fairly good ejection fractions. So to follow this approach of differential sizing, we have to know the equipment, know the size, know the valve and how it reacts. You know, the Sapien 3 not only differentially inflates, but it also shortens from the bottom. So also placement is very, very important. And to place it in the proper location, you need to have meticulous CT sizing of both the annulus and the LVOT. And you need to practice it, and we learn every day. When we looked at variable sizing, again, you want it to fit the patient, not the other way around. So we want to try and really individualize the patient and the valve and how we place it into this patient. And when you look at how many patients we do differential sizing with, it's in the order of 1 in 3 that will overinflate. And usually a smaller valve, a 20 millimeter valve by 1 cc, a 23 by 2, a 26 by 3, and a 29 we can go up by 4. And again, you always run the risk of when you go higher that you may induce a central leak, but we have not seen that to be a problem as long as we maintain those parameters. And procedural characteristics and results. Again, this was the time where we were changing. We used to do all of our patients under full anesthesia, transesophageal echo, sizing with transesophageal echo at that time. And then we switched over to a more percutaneous awake approach. As you can see, rarely use apical or other means of access. And 2/3 of our patients at that time, it's probably higher now, at that time we're actually being discharged the next day. So we were very proud of that. We ramped up very quickly. And the 3M study, which I'll talk about tomorrow, really initiated that for us. And you can see most patients by day 2 are gone. They're gone home, not gone. Death rate, a respectable 2% with a fairly high STS score. And the pacemaker use was about 6.9%, which when you look at series is actually a fairly good number, all comers. I'll talk a little bit, I'll show you a slide on that it's actually very predictable who gets pacemakers when we do this. And we avoided annular rupture and left main occlusion, which is only 100 patients. You may avoid that anyway, regardless of what approach you take, because it's only about 1%. So, pacemaker. This is something we're studying more, and we're working with our electrophysiology people. Something that we haven't really done in the past. We've just called them up, said this person needs a pacemaker, and they put it in, and that's done with. But now we're proactively getting them involved beforehand. And even in this number of patients, as soon as patients have a right bundle branch block with either a first degree and or a left hemi block, we're noticing very high rates of pacemaker, even in this differential sizing that we do. So we are actually, when patients have a right bundle or trifascicular block, we're actually sending them to the EP people prior to our TAVR to assess for possible permanent pacemaker placement prior to, because when they actually monitor a lot of these patients, they do have an indication for a pacemaker. So this, again, something that we're learning. But you can see when patients have normal ECG, essentially normal conduction, our rate of pacemaker use is less than 2%. So we think that's very respectable numbers. Post-dilatation, we are still doing it even after this, but it's not that often. So you look at nominal ones, are 6%, and ones that we're already overfilling, about 14%. And again, we don't go above what I said, the 1, 2, 3, 4 rule, but we will go up to that. The other thing to mention is we do not undersize, at least in our hands. We feel undersizing may not allow that valve to expand properly, and the hemodynamics of the actual leaflets may be changed to a point where the longevity may be altered. So we're very careful when we, with doing that, we don't undersize. And you can see the results, again, are fairly good with the amount of paravalvular leak we have, no central aortic insufficiency applying these rules, and the gradients are respectable afterwards. So, again, this very niche discussion, we started off that way. Well, I think right sizing is very important and can be done. Low rates of permanent pacemaker use and paravalvular leak can be obtained by doing this. Annular disruption, possibly abolished, but never going to happen. There are going to be, hunks of calcium do act funny sometimes and don't do what we want them to do, just like in angioplasty when we do it, sometimes things happen. And I think this approach does facilitate next day discharge because we're keeping those permanent pacemaker rates as low as possible. And we know if they need another procedure, especially an elderly, frail person, they just don't do well. And we think it's a way to contain costs, again, by lowering the pacemaker use. So again, just a few thoughts on variable ballooning, and I hope this is helpful in the use of this. Thank you.
Thank you very much, Dr. Velianou. Any questions?
Thank you. It's a very interesting table. I've read the paper a long time ago. We'll revisit. One of the things about Sapien 3 is it's taller in height. So there are some patients, especially size 20-23, where the ST junction is a bit lower down or sinuses are narrow, and then we try and use the lower size and then overinflate it.
Yes.
Is that your practice as well now?
Absolutely. So I didn't get into all that, but a few years ago we added an interventionalist who's very skilled, who actually did a formal year of CT training in Mass General 10 years ago. But it wasn't a structural, more than 10 years ago, it wasn't structurally oriented. So we do all those measurements as clearly shown in a great talk earlier on by a radiologist from EIA. So we measure all those sizes and we look at where we think the height's going to end up being, and we are worried about STJs, we are worried about left main leaflets. So absolutely, if we see other aspects that are hazardous, we do go to a smaller valve, and we will implant it lower if we have to stay away from those areas. But absolutely, I think as soon as you go to sometimes a valve that looks like it's in the zone to use a higher valve, we don't like to do that because we are worried about those complications.
And can I ask one more question? Is about underfilling. We do that regularly. We are not that worried because I think that there is always a size range of the annulus. Say for 23 is between 19 and 22. So when we implant it in say 19 annulus, the 23 never becomes 23 anyway. Yeah. So we are not that worried. Of course, I think we need industry guidance in terms of leaflet durability, etc. Especially with Sapien 3 because it's an intra-annular device. And I think the last question is size 20. We are very hesitant in using size 20 because there's a lot of recoil. So just thoughts from you.
Yes.
Possible.
I'm hesitant using size 20 as well, and part of it is preventing size mismatch. But generally, the people who are getting the 20 are, the 90-pound woman who's very small, and it suffices. But you have to be very careful putting it in. You have to be careful like you were back with the XTs, the 23 XTs, which again, smaller height, and just really making sure, and we go very slow, and we keep the balloon up a bit higher because of that recoil, so absolutely. And again, you have to be careful on those smaller valves where you place it, because you have that shortening. So with a 20 valve, if you have to overexpand, you have to be very careful. We like to place not 2080, we like to place 1090, but you have to be careful when you think you're going to overexpand, absolutely.
Annular rupture is indeed a catastrophic complication.
Yes.
Probably the most hostile environment is the bicuspid aortic valve. What is the current rate of annular rupture in bicuspid valves?
Well, in the published series, as discussed earlier, published series are probably 1 to 2%. And again, it may be even higher than that. We don't know because it may be publication bias where people are presenting the good results. But it's, again, it's not something to be taken lightly, and especially if there's aortopathy involved, I think these valves and the aorta acts differently. So I think really this is something that should be hopefully done by people who've maybe done a few more, not because they're better, but just they have a bit more experience. So we have to be careful with these ones.
So our strategy in Colombia is if it's a tricuspid valve with high-risk anatomy for annular rupture, we prefer to do it under general anesthesia and echo guidance. We always inflate the balloon very controlled, usually by a senior operator. So we also see visually when it engages and on echoes, so as to avoid this problem. In bicuspid, what we do regularly is we do BAV. And the reason to do BAV is if you see the balloon selectively inflating on one side, which is generally a case when one leaflet is very calcified and fixed, as we see many times in surgery, and the other leaflet is mobile, related. That's the time when we are very careful because it can, when you inflate the sapien, it can actually go on one side completely. And I've had the misfortune actually 2 times, not once, but twice, of having this complication. And I've learned from that mistake now. And we are very careful about oversizing in bicuspid. We generally tend to put a smaller valve compared to if it was a tricuspid of similar dimension.
Just two comments. This is exactly what Vinny said. Probably this is a population that you should go for a self-expandable valve. And BAV is very helpful to make this decision. And the second is we also undersize very often. We don't worry about this. And the reason is when you're in the gray zone between two different sizes, I always prefer to go for the larger size. So if I have any paravalvular regurgitation, I can add some more volume and take care of that instead of going into the lower size and then regret about this decision and leave the patient with paravalvular leak. But on the other hand, you're right, I'm still not convinced that undersizing doesn't have any long-term effect on the valve function durability. It's something we do. As Vinny said, it should work because many times the calcium restricts your valve to a lower size than what is made for, and still we don't see any problem. But we certainly need more long-term data for this practice of today to widely accept it and recommend it. So.
Okay, thank you very much. The next speaker is Dr. Pilatis from ESO General, and he will speak about transcatheter aortic valve